Craig, welcome, and the floor is yours.
Thanks very much. Well, afternoon, everyone. I'm Craig Thorley from IPPR, the Institute for Public Policy Research, and I'm here this afternoon to talk you through a presentation on children and young people's mental health. Before we get started, I thought I'd just introduce IPPR very briefly. So we are the UK's leading progressive policy think tank. We're a registered charity, been going for about 30 years, and our aim is to provide evidence-based ideas for reform, persuade people with the power to bring about positive change to do so, and we conduct rigorous research across a wide range of public policy areas, domestic public policy areas. I work in the public services team, and we cover health, education, a little bit of criminal justice. And increasingly, we're also involved in establishing new institutions. So a couple that you may or may not have heard of are Frontline, which aims to get more people into children's social work, and Think Ahead, which aims to get more young people into mental health social work with adults. So given that the majority of your presentations today are going to be on the law, policy and practice on restraint reduction specifically, I've been asked to give a more general overview of some of the broader issues around children and young people's mental health, and specifically to think a little further upstream, focusing on children and young people with emerging mental health conditions, specifically within a secondary school context. And the ideas and findings that I'm going to be talking about predominantly relate to a report that we published earlier in the year called Education, Mental Health, which consisted of a team of us at IPPR going around the country, visiting schools, visiting children and young people's mental health services, speaking to experts and getting to grips with some of the data around this problem. So, the presentation will be divided into two parts. Firstly, I'm just going to rattle through some of the statistics around children and young people's mental health, so prevalence rates, different kinds of conditions, then go on to talk about the pressures on both NHS and non-NHS children and young people's mental health services, then talk about the view from secondary schools, specifically some surveys of head teachers, and then go on to talk about the value of early intervention. And then secondly, I'm going to talk about secondary schools in a bit more, with a bit more specificity. So talk about what a whole school approach might look like, how we can think about breaking down roles and responsibilities with regards to mental health within a school context. And then finally go on to think about what some of the barriers are to improving schools' ability to deal with this issue that came up through our research, and what some solutions to overcome those barriers might be. So, children and young people's mental health has obviously been described as a hidden epidemic by the Royal College of Paediatrics and Child Health in 2010, and is consistently identified as a primary concern among various stakeholder groups. So 2/3 of teachers identified it as their top concern back in 2015, 40% of parents identified it as their top concern in 2015 also. So what do we know about how many children and young people are affected? Well, the best data we have, frustratingly, dates all the way back to 2004, which is when the last prevalence study was conducted by the ONS. And that tells us that 10% of 5 to 16-year-olds have a diagnosable mental health condition, which translates roughly into three children in every classroom. Conditions are more common among 11 to 16-year-olds. So it's 7.7% of 5 to 10-year-olds compared to 11.5% of 11 to 16-year-olds. But among both of those age groups, prevalence is higher among boys than girls. And the two most common types of conditions that children and young people experience are behavioural disorders and emotional disorders. So where behavioural disorders are defined as those where symptoms are so severe as to cause distress or impairment in a young person's functioning, and they're twice as likely in boys compared to girls. Emotional disorders, primarily anxiety and depression, there's been a long-term increase, but a particular acceleration since the mid-1980s. And of course, emotional disorders can also have physical symptoms that might manifest in the classroom. So lack of concentration and fatigue being two of those. There's also, of course, other less common types of conditions among this age group, so psychotic disorders being one such. Well, how are things changing? Well, luckily there is going to be another prevalence study that's being conducted currently and is due to report on 2018, so we'll be able to know for sure how things have changed from 2004. But while we await that data, we have to kind of use a number of proxies to try and unpick what exactly is going on. And this graph here demonstrates one of those. So the two lines are variations on hospital and A&E admissions for children and young people who have self-harmed. And you can see a dramatic increase since 2010. And the staggering statistic is that self-harm hospital admissions went up by over 50% in just 5 years between 2009-10, 2014-15. And similarly staggering is the fact that calls to Childline, where young people report suicidal thoughts, increased by a third, 33%, in just 2 years between 2011 and 13. So although we don't have that hard prevalence data, it's pretty clear that there's a massive issue going on, and there is definitely a crisis in the mental health of children and young people in the UK. So what do we know about why things are changing? And what factors might there have been to increase the stresses that children and young people face? And I asked this question given the quote that you see at the top there, which is from a leading researcher on this area, who says that if adolescents have been experiencing more stress, there is enough evidence to suggest that we could expect this to be related to rising trends in mental health problems too. So what life situations are happening to children and young people today that may not have happened so often in the past, that means we're seeing that sharp increase in self-harm admissions and other proxies for mental ill health? Well, the first of these is parental mental ill health. This is considered to be the best established risk factor for the development of emotional problems in children and young people. 2 million adults are in contact with specialist NHS services, or were in contact in 2014-15. And that's despite the fact that we know that 75% of adults who experience mental ill health receive no treatment whatsoever. So if 2 million are receiving treatment, the overall number is going to be much, much higher than that. And that has a significant effect on children's mental health also. Another one is changing levels of socio-economic disadvantage. So children and young people in the poorest households are 3 times as likely, or 3 times more likely, to develop mental health problems than those in better off homes. And this is due in part to the fact that stressful and unpredictable life events occur more often to young people in low versus than high socio-economic status contexts. And there's a number of key indicators that kind of signify why we may have seen that particular acceleration in children and young people's mental health problems since 2010. So firstly, real wage stagnation. Median real wages increased annually by an average of 2% between 1980 and the early 2000s. But between 2008 and 2014, after the financial crash, they actually fell by 8 to 10%. So people's wages went down significantly, which is obviously going to affect parental mental health, as we just saw. Similarly, child poverty. So between 1998 and 2011, the number of children living in poverty fell from 4.4 million to 3.6 million. But the Institute for Fiscal Studies have projected that this is going to go back up to 4.3 million by 2020, which will mean that we're back to where we were in terms of child poverty in 1999 in 2020, which is again quite staggering. And there's some good NHS England data, which I haven't included here, but if you're interested, you should definitely look up, which shows a clear correlation between the areas of the country which have the highest levels of child poverty and the areas of the country which have the highest levels of child mental ill health. And then lastly, food bank referrals. So this is another crazy statistic. In 2008, there were 26,000 referrals of families to food banks. By 2014, that had risen to 1.1 million. So that's an increase of over 4,000% in 6 years. Another causal factor for mental health among children and young people can be the impacts of digital technologies. So cyberbullying is a big one that often comes up. Childline report an 87% increase in the number of reported instances of cyberbullying that come into them. There's also been a proliferation of websites that reinforce harmful behaviours, so self-harm, eating disorders, that kind of stuff. And sexting is another big one. So the NSPCC have reported that between 15 and 40% of children and young people are directly involved in sexting on a regular basis. Increased levels of diagnosis is another reason why things might be changing. So improved public attitudes towards mental health, the relative success of anti-stigma campaigns such as Time to Change, and this could have led to an increased willingness among parents to seek help. Changes to family structure, this is an interesting one. So the proportion of children living in lone parent families tripled between 1972 and 2006, reaching 25%. And it's been estimated by research that isn't ours, but that we quote in our research, that between 15 and 30% of the change in emotional and behavioural problems observed between 1986 and 2006 can be directly attributed to changes in family structure. So potentially up to a third of that increase over that 20-year period, research suggests can be attributed to family breakdown and changes in family structure. And finally, educational pressures. So over the past 20, 30, 40 years, there's been a gradual increase in the number of children who are sitting high stakes exams. And this dates back to the introduction of the GCSE. And unsurprisingly, perhaps exam pressure is noted as the most common worry among 10 to 16-year-olds. So the argument that we make is that schools shouldn't be forced into a position where there's a trade-off between educational progress and mental well-being. Too often we argue the kind of incentives that are placed on schools force teachers and school leaders into a position where one is kind of sought potentially at the expense of the other. And we think that's the evidence shows that that's a disastrous situation. So pressures on services. Well, overall, mental health takes up 23% of NHS activity, although spending is equivalent to just half of that. Parity of esteem obviously became enshrined in law during coalition, but it's certainly yet to be realised in practice. So in 2012-13, mental health made up 6%, or 6% of the mental health spend, which is already very low, went to children and young people's mental health services, which equates to just 0.7% of the overall NHS spend in that year, despite the scale of the problems that we just saw. Similarly, 60% of local authorities cut or froze their budgets in this area between 2010 and 2014, and a Health Select Committee heard evidence that the reason for this was because these services were considered as an easy target and not core business. And the graph you see there on the right-hand side is local authorities' early intervention allocation. So this is the money that goes to local authorities to spend on mental health and early intervention, among other things. And that fell by 55% over that 5-year period, down to 1.4 billion. So the effects of all of this, we argue, is that when you have increasing prevalence and big pressures on services, you're getting a perfect storm, which often manifests itself in a secondary school setting. And this seems to be backed up by what teachers and school leaders are telling us. So here's just, I won't rattle through all of these, but, self-harm, a 57% rise since 2010, depression, 85% rise. So teachers are crying out to us that this is a massive problem and that they need more help. So early intervention is something that gets talked about a lot in this sphere, and is something that's not particularly controversial, obviously, and that most people realise the benefits of. So there's obviously big health-related benefits to the individual that receives early intervention help, and there's obviously subsidiary economic benefits to society if someone goes on to receive an improved education as a result of receiving early help, or that they're less likely to encounter negative life outcomes like going to prison or interacting with the criminal justice system. But despite our knowledge about the benefits of early intervention, it remains the case that 60 to 70% of children and young people don't receive appropriate interventions at a sufficiently early age. So we need a fundamental rethink. And here's just a kind of visual representation of the kind of situation that I've just described. So apologies if you can't see it particularly well, but what you get when you get reduced budgets in children and young people's mental health is that early intervention services are the things that get scaled back first, which means fewer children and young people are able to access early help. More low-level conditions are allowed to deteriorate. This increases demand for specialist services, which then become under increased strain and absorb more of the overall budget, which means there's less for early intervention. You get trapped in this vicious cycle. And I think this is definitely the story of the last, at least the last 5 or 6 years. So, what can we do about all of this? Obviously, one way of solving this problem is for the system to become more integrated. Oh, how am I doing for time?
You're fine.
Cool. And to its credit, the government seems to have realised this, and a lot of its, or the previous government as well, and a lot of its initiatives seems to be based on the need for more integration. The most prominent of these is the transformation agenda that was kicked into life at the end of the coalition government. And the transformation agenda aimed to get NHS providers, voluntary sector providers, schools, the whole system together to think about the kind of provision that should be delivered locally and the best way to do that. And I'll go into talk a bit more about how that's played out in practice. But for now, it's just worth saying that even within that integrative potential future, we think more needs to be done to ensure that schools are at the heart of integrated early intervention provision. This is because schools have the potential to improve accessibility because they have a direct line to potentially hard to reach families. So a big problem in this sphere is children and young people who are referred to NHS services and then don't attend, so DNAs tend to be quite high. By basing things in school, you can better address some of the school-related stresses that contribute to mental health problems, and you can significantly ease pressures on the more specialist parts of the system further down the line that we just saw in that vicious cycle. So what does mental health provision actually look like in English secondary schools? Well, we came up with thinking about it in this relatively simple way. So we broke it down into 3 categories. The first is prevention and promotion. So this is largely skills-based and focuses on the teaching and development of skills, strategies and behaviours that could help to protect pupils from developing mental health problems in the first instance. So this is where a lot of the things that you may have heard of recently, so teaching kids resilience, character education, increasing the amount of mental health that's included on PSHE curricula. All of this stuff falls into this prevention and promotion sphere. The second encompasses early identification, triage and referral. And actually, I should have just said prevention and promotion is relatively widespread. So 95% of schools, secondary schools, report teaching mental health in the curriculum in one form or another, and 81% report engaging in awareness-raising activities about mental health, like assemblies, special assemblies. So on the second category, early identification, triage, and referral, this is slightly more specialist and requires the input of teachers, parents, and pupils, among others. So one thing that schools can do in this category is to use monitoring and screening tools to try and get an early idea of fluctuations in the well-being of students so that problems can be identified as early as possible and support plans can be put in place, and to minimise the incidents that things are missed. And about half of schools report using such monitoring and screening tools. So that might just take the form of a questionnaire every 6 months or every year to try and get an idea of how kids are doing in terms of their well-being. So schools are relatively well equipped to do that, but what they're less able to do is to differentiate between different severities of need. So once you've got that data and you understand in general terms the well-being of a child, it's that next step of knowing what to do with that and what that means for potential diagnoses or potential forms of treatment that's less well ingrained in the school system. So 86% of secondary schools report having some form of pathway into CAMS, Children and Young People's Mental Health Services, but less than half of those are deemed to be effective. So having that pathway in place is one thing, but having it in place where it's actually utilised effectively seems to be a completely different picture. And then the third category is early intervention. So this is targeted evidence-based intervention. And we distinguish in our report between a hub model and a provider model. So a hub model might be where you have a system like Place to Be, so a kind of external system that comes into the school and has its own structures and that can intervene early to support children's mental health and well-being. A provider model might be where the school organises things itself and brings in individual counsellors, educational psychologists, and kind of coordinates that itself. The majority of schools do commission some form of mental health expertise, 75%, but the fact that 25% don't is still a massive issue. And then we asked ourselves, how should the roles and responsibilities of teachers and other school staff be divided with regards to pupil mental ill health? And one of the big things that we found in our research, and one of the big things that we detected, was just a real nervousness and lack of confidence on the delineation of roles and responsibilities with regards to mental health within a school setting. So particularly among teachers, they reported feeling exposed to deal with issues that they weren't sufficiently trained to do, that they just didn't necessarily come into the profession to deal with. But elsewhere in the system too, there was just, in almost all the schools that we went to and all the people that we spoke to, there was just a real lack of clarity on who is well placed to do what to support pupils with mental health problems. So we make, and this is a kind of suggested breakdown that we came up with based on what we heard. But I think the key here is that those green squares there, the key is having some means of coordination of all of these different people. And it's worth saying as well that not all schools have all of these people. But the key is having some category of staff within a school who have responsibility for coordinating everyone else who has some role in pupil mental health. And we make the argument that that's the pastoral staff, and we saw some examples of where that can happen really well. But obviously what shouldn't be happening is teachers engaging in evidence-based mental health interventions for kids with emerging problems, is teachers conducting triage and deciding on what a potential diagnosis might be and what support should be. Teachers are obviously well placed to do all of the promotion, prevention stuff, early identification of problems in the classroom. But when you get onto the more kind of medically based, I guess, parts of the system, that's when you need CAMS professionals, people like psychologists, people like school nurses, potentially people like counsellors coming in, being coordinated by the pastoral staff within the school. One recent initiative in this space is a CAMS school link pilot, where a number of schools have a single point of contact within their local CAMS system who they can refer kids to relatively easily, get advice from, but who's based externally. That seems to be going quite well. Not all of the evidence is back on exactly how well that's doing. But we make the argument that you could even take that one step further and have mental health professionals based inside the school for 1 or 2 days per week to deliver some, to both support teachers and pastoral staff and counsellors and the rest of the people based in the school, but also to deliver some actual evidence-based early interventions to the young people that need it.
5 minutes, Craig.
Cool. So what's the implications of all of this for restraint reduction? So potentially, by having a clear whole school approach to mental health and wellbeing, which covers all of the 3 categories which I've described, it means that you've got a more clear understanding within the school and extending beyond the school into parents and other people in the community about what it exactly is that people are trained to do, what they're not trained to do, which could potentially minimise incidents of unnecessary restraint. But the key things, the key features that I think came up through our research that apply to this discussion on restraint reduction are clarity, expertise, integration and coordination. And if you have those 4 things within a school setting, it seems entirely plausible that incidents of restraint reduction would potentially go down. So what are the barriers to reform and how might we overcome them? So we identified 4 in our research, 4 big barriers to reform that we think need to be addressed if schools are going to be able to meet the mental health needs of pupils more effectively. The first of these is a relatively obvious one, funding. So schools largely lack the funding they're required to provide pupils with targeted mental health support. They've long been unable to access sufficient health funding or services paid for by health providers that would allow early intervention services to be provided on site. Following the introduction of the transformation agenda, the effect of this inability to access health funding is that schools are not being recognised fully within local children and young people's mental health systems. So a thing that came up repeatedly when we went around the country visiting schools is, we'd love to get a counsellor to be able to deal with this kind of stuff and to support pupils. But if it's a choice between buying textbooks because ours are falling apart and getting a counsellor, we're going to get the textbooks every time. And that's something that came up time and time again. But we know now that the money is out there. So the government, as part of this transformation agenda, has pledged to invest 1.4 billion up to 2020. So we know the money's out there. The question is just, how do we unlock it? How do we stop it being siphoned into other areas of NHS expenditure that are nothing to do with mental health? And how do we get more of it to schools to do more of the kind of things that I've described? And the most immediate argument that we make about that is to just ring fence this 1.4 billion. At the moment, it's not ring fenced, and there's a lot of evidence that it's just being spent on completely unrelated things, which makes a slight mockery of the whole transformation agenda. Second big problem, commissioning and representation. I'll rattle through these very quickly. So schools don't have established mechanisms for affecting how NHS money is spent on mental health. So this pie chart here, some schools were surveyed to see if they'd contributed to local transformation plans. 75% said they hadn't, despite there being clear guidance around these plans that schools are engaged with as a key part, and it was supposedly part of the criteria for approving these plans that schools have been engaged, and yet it looks as though 3/4 of them weren't. And the bar charts you see on the side there indicate that, as well as not being aware of the plans, the majority of schools don't anticipate being involved in delivery of them in any way and didn't input into them in any way. Third big barrier is the quality of the support, the mental health support that schools are able to access, particularly school counselling. So hopefully you can all read this quote. This was a quote from a head teacher who said, it's individual schools buying in individual counsellors. It's not an organisation, so they're not under the same scrutiny. There isn't the same auditing, there isn't the same evaluation. It's just different schools buying in different services and people with different qualifications and different experiences, often from an adult counselling service rather than a young person's counselling service. So that was an issue that came up quite a lot, that schools would break their backs to get a bit of money for a counsellor, but because they didn't necessarily have expertise on how to commission a counsellor or who the best counselling services was, they would very often end up with a counsellor who may have never worked in the school before. They didn't know how to supervise them, so you just had this kind of slightly Wild West system of, and it's not this bad everywhere, obviously, but a slight Wild West system where there's counsellors operating in school settings who don't have masses of experience and who aren't being supervised properly.
You're in the red zone now.
Okay, this is my last slide. The last barrier was accountability. So we argue that if you give schools all of this money, if you give them all of the expertise they need to provide pupils with support, then it also makes sense to hold them to account for the quality of the support that they provide. And there were some moves to this direction last year. So the Ofsted framework was updated to include more references to mental health and wellbeing in September of 2015. And we did a random sample of 50 Ofsted reports that were published since then, and only 1/3 of them make any mention of mental health or wellbeing whatsoever. Like literally, the words mental health or wellbeing weren't in 2/3 of these reports, despite it being in the criteria. So we argue that Ofsted should inspect schools in part according to them having some sort of plan which talks about the quality of their relationships with the NHS services, the fact that they've thought about how to divide roles and responsibilities, and you could quite plausibly include in there having thought hard about ways to minimise the incidence of the use of restraint. So that's all I really wanted to talk to you about today. I hope it contains some interesting reflections about mental health more broadly, and stimulate some thinking on the specifics of restraint reduction, which I'm sure you'll get into in more detail today and tomorrow.
Many thanks.